A 59-year-old man walks into clinic, frustrated and pale. "Doctor, these headaches come out of nowhere. My heart pounds, I turn white as a ghost, and I feel like I'm dying." His blood pressure reads 168 over 96 millimeters of mercury, despite chlorthalidone, lisinopril, metoprolol, and diltiazem. This isn't new hypertension. It's resistant hypertension, progressively worsening over a year. Yet, his cardiovascular exam is unremarkable: no murmurs, no thyromegaly, and no edema. So why does his blood pressure refuse to yield? Act 1. The familiar suspects. The residents start the usual detective checklist for secondary hypertension: renal artery stenosis, check renal brutes. Primary aldosteronism, look for hypokalemia. Cushing syndrome, watch for striae and obesity. Sleep apnea, question about snoring, fatigue. Medication non-adherence, always possible. But this patient's labs show normal potassium, no metabolic alkalosis, no Cushingoid features, and he's adherent. Something else is stirring behind the scenes. Act 2. The clues of the adrenal shadow. The story deepens. He reports episodic headaches, profuse sweating, palpitations, and panic-like fear. But the physical clue is subtle: pallor instead of flushing. During one of these episodes, his home BP monitor captured 210 over 112 millimeters of mercury. Beta blocker therapy made his symptoms worse, another ominous hint. The team starts thinking of catecholamine surges. But not every catecholamine-secreting tumor sits in the adrenal gland. Act 3. The invisible culprit. The initial suspicion is pheochromocytoma, yet the attending reminds the group, not all catecholamine storms start in the adrenal medulla. Some begin along the sympathetic chain, hidden, elusive. That's paraganglioma. Paragangliomas arise from extraadrenal chromaffin cells. They secrete norepinephrine, leading to sustained hypertension rather than purely episodic attacks. Act 4. The diagnostic chase. Before reaching for the CT scanner, the team follows the right sequence. Step 1. Biochemical proof. Plasma-free metanephrines or 24-hour urine fructionated metanephrines and catecholamines. Blood is drawn with the patient supine and calm because posture and stress can cause false positives. The results: normetanephrine, 5 times upper limit of normal. Metanephrine, normal. Pattern suggests norepinephrine predominant secretion, more consistent with a paraganglioma than adrenal pheochromocytoma. Act V, the reveal. Now, with biochemical confirmation, the search for the hidden source begins. Adrenal CT, normal adrenal glands. But just below the renal arteries, a 3.8 centimeter retroperitoneal mass appears, adjacent to the aortic bifurcation. High T2 signal on MRI, light bulb bright, the radiologist smiles knowingly. Diagnosis: functional extraadrenal paraganglioma. Because these tumors can occur anywhere along the sympathetic chain, MIBG scintigraphy or PET imaging may be required to localize multifocal disease or metastases. Act 7. The cure before the knife. The endocrine team knows the golden rule: never touch the tumor before blocking the alpha. Preoperative preparation: alpha blockade for 10 to 14 days. Liberal salt and fluid intake. Beta blocker only after alpha control. Definitive treatment: surgical resection, performed with invasive BP monitoring and volume optimization. Post-op, the BP normalizes. Follow-up metanephrines are normal. The phantom surge is gone. Act 8, reflections and take home. 1. Not all catecholamine storms arise in the adrenal. Think paraganglioma in catecholamine excess without adrenal mass. 2. Biochemical confirmation precedes imaging. 3. Pattern of secretion guides localization. Norepinephrine excess extraadrenal source. 4. Always block alpha before beta. 5. Genetic testing is essential, as 30 to 40% are hereditary. Epilogue. At follow-up, the patient's blood pressure reads 122 over 74 millimeters of mercury, off all but lisinopril. The panic attack's gone. What seemed like psychogenic anxiety was actually a retroperitoneal tumor whispering catecholamines. When hypertension resists reason, look beyond the adrenal. Sometimes the villain hides in the shadows of the aorta.